Morning, everyone. Welcome to the Grand Rounds for the Department of Medicine of Mount Sinai. I'm pinch hitting today for Dr. David Thomas, and we'll go ahead and get started. I'm going to hand it off to one of our chief residents, Dr. Emily Levin, for the introduction.
Thanks, Dr. Kim. Good morning, everyone. Welcome to Grand Rounds. Today, we're joined by Dr. Lynne Richardson, who's a professor of emergency medicine, of population health and science policy, and of artificial intelligence and human health at the Icahn School of Medicine at Mount Sinai, and funding co-director of the Institute for Health Equity and Research. A practicing emergency physician, she's one of the most successful NIH-funded investigators in emergency medicine and one of its most respected research mentors. Her work has been funded by the National Institutes of Health, the Agency for Healthcare Research and Quality, and the Centers for Medicare and Medicaid. Dr. Richardson is a nationally recognized expert in health services research who has made highly influential contributions to eliminating healthcare disparities in both the research and policy arenas. She's an expert on community engagement and a national thought leader in the ethics of conducting emergency research. She often uses clinical and administrative data to investigate issues of access, quality, and equity. Dr. Richardson is a member of the New York City Board of Health, past chair of the American College of Emergency Physicians Public Health Committee, a current member of the Board of Trustees of the Emergency Medicine Foundation, and the chair of the Health Services Quality and Effectiveness Study Section. She's an elected member of the National Academy of Medicine and serves on the board on health sciences policy of the National Academies of Sciences, Engineering, and Medicine. As we enter the second week of Black History Month, Dr. Richardson will be discussing achieving equity in health and health care. Thank you very much for joining us today, Dr. Richardson.
Thank you for that lovely introduction, Emily, and good morning, everyone. I am delighted to be here, and I'm going to spend some time talking to you about something that really has been my professional and personal focus for most of my life, if not career. As you've already heard, my research has been funded by a variety of organizations. I am a member of many affiliations, but I do not represent any of them in this talk, and I have no financial conflicts to disclose. So we're going to talk a little bit about what racial and ethnic disparities in health are. We're going to spend more time talking about the causes of health disparities because I think it's important to understand where they come from. And then I want to talk specifically about health care disparities because I think that's really where our role as providers is key. And if there's any time left, I may talk a little bit about our new Institute for Health Equity Research. So let's get started. Contrary to what's written in the Declaration of Independence, in the US, not all are equal. And there are decades of evidence that document the fact that for certain racial and ethnic groups in this country, there are longstanding, persistent differences in all kinds of health outcomes. They have poorer health status, lower life expectancy, higher death rates, higher disease burden across a whole range of conditions. And these are empirical facts. And I want you as educated people to accept that the empirical evidence really is overwhelming. I could spend the whole hour just showing you the data that documents these disparities, but I'm only going to show you this one. This is US life expectancy by race. Life expectancy at birth. And you can see at the beginning of the 20th century, the spread between Black and white was almost 15 years different, with whites living to be about 47, 48 years old, and Blacks having an average life expectancy of 32. As time progressed, the gap did close. And as you can see, life expectancy has improved for everyone. But even as we were entering the 21st century, the gap was still very substantial, more than 7 years. And this is really the point where eliminating health disparities became a national goal by our public health agencies, with lots of focused attention on eliminating health disparities. And as you see, we have made some progress. This is 2018 data, and the gap has narrowed. but it still exists. After more than a century, there are still persistent racial and ethnic disparities in health status and health outcomes. So that's a matter of empirical fact. The question, of course, is why. And so health is a complex state, and there are many things that go into determining how healthy you are. There certainly are genetic determinants, and we know more about that than we ever have before. There are biological vulnerabilities. There are differences in behaviors, both risky behaviors and health-promoting behaviors. We've heard a lot about social determinants, and I'm going to talk a little bit more about some of those, or psychological determinants, environmental determinants. All of these things contribute to our health. And so all of these kinds of factors contribute to the disparities in health that we see between certain population groups. But there are a few things that I think need to be said before we go on if we're to understand health disparities. And there's been a lot of discussion in both the academic and lay press about this in recent years, and I think a lot of confusion. So it is certainly true that race is not a biological taxonomy. Race is a social construct. It's a way of categorizing people based on appearance, based on the way we look. And so this has led to the idea that researchers from various scientific disciplines shouldn't talk about race, because if we talk about race, that turns it into a biologic category somehow. This is really a simplification of a very complex issue. I've said that there are multiple determinants of health and multiple components of health disparities, but the existence of racial differences in health is an empirical fact. And so to understand that, we must study race. Scientists of all disciplines must study race. Now, we know race is related to ancestry, and this has made the conversation even more complex. Now, the causal mechanism of this relationship is easy to understand. Genes contribute to your appearance, and race is a social construct based on your appearance. And so while it is true that there are certain genes and markers that have varying frequencies among different races, genomic science has actually confirmed that race is not a biological taxonomy, because the variation within any given race, the genetic variation, is much greater than the differences between races. Race is also related to socioeconomic status, because in this country, if you are Black or Latinx or American Indian, you're more likely to be poor, you're likely to be less educated, you're less likely to own property, you're less likely to have a well-paying job. And so all of these things are related to each other, but race is this social construct which appears to be related to health, undeniably is related to health, and we have to understand the underlying mechanisms. And so what really contributes to health disparities is the fact that racial and ethnic minorities live in physical and social environments that lack the resources needed to generate and sustain health. And I'm going to spend a little bit of time now talking about these environments. So where you live matters a lot in terms of your health. What we call the built environment, the physical environment, gives you differential exposure to toxins, pathogens, and carcinogens. Where you live may expose you to risks of injury and interpersonal violence, the availability of healthy foods, access to safe venues for physical activity, places for adults to walk and children to play. All of these vary by where you live. And living in a particular place may facilitate risky behaviors. If you grow up on a block where drug dealers are selling drugs every day, you are more likely to try drugs. This is not to say that there is not drug use in affluent suburban communities, because we all know that there are, but the differential risk is different depending on where you live. And the proximity to healthcare providers also varies by where you live. So place, physical environment, built environment is a very strong determinant of how healthy you are or your possibilities of being healthy. And in this country, where you live is highly dependent on race, because even today, America is a highly segregated country. So this is a graph of something called the Dissimilarity Index. It's based on census data. And it's a really simple context, and you can use it to look at segregation really between any two groups. And the way this works is, I'm showing you the Black-White Dissimilarity Index. And so this is the percent of the Black population that would have to move for the entire population to be evenly distributed across whatever geographic area you're looking at. And so the example I usually start with is South Africa under apartheid. Not that many of you are old enough to remember when apartheid was a fact, but I assume you read about it or heard about it. It was a completely segregated society with all Blacks tightly contained in townships, requiring passes to leave those townships to perform any of the activities of daily living. And so the dissimilarity index for South Africa under apartheid approached 100%. What's interesting is that we see the dissimilarity index for many American cities approaches that of South Africa under apartheid. This is New York City. We are not first, but we are very high up. Chicago, Los Angeles, Baltimore. You see from every region in the country, in large cities, we are a highly segregated society in terms of residential segregation. And we know this. We call New York City a city of neighborhoods. You turn the corner, you're in a completely different place. And those neighborhoods tend to be homogeneous by race. So let's look at it a different way. This is a map of New York City. You'll recognize this is Manhattan, the Bronx, Queens, Brooklyn, Staten Island. And the darker the blue, the higher the percentage of residents in that particular neighborhood who are Black. Now try to hold that picture in your mind. This is a map of percent of residents living in poverty, and you see the darker colors in many of those same neighborhoods that had high percentages of Black residents. Let's look at some health conditions. This is pediatric hospitalizations for asthma. And again, you see the highest rates in those same neighborhoods where there's high percentage of Blacks and a high percentage of people living in poverty. Now, it's not so surprising perhaps as something like asthma, which is very sensitive to environment, would have this kind of pattern. If you're living in older housing stock, more likely to have allergens and irritants, or like you live in a neighborhood with poor air quality, you can see how that would affect asthma. But I could show you 50 maps of different health conditions that would have the same pattern. This is low birth weight infants. And again, you see the same patterns of where this occurs based on where people live. And in fact, if we were to look at the map for COVID in New York City, you would see exactly the same patterns, because COVID really unmasked the importance of these social determinants in predicting health outcomes. So who got COVID? Contracting COVID depends on where you live. Do you live in a household with many other people? That's an intergenerational household. Do you have a job that you can't do remotely, where you have to leave your home and take public transportation and go to a job where you interact with the public in a grocery store, or as a hospital housekeeper, or as one of the essential workers who had to continue to put themselves at risk to do their job. And who died from COVID? Well, again, with an unequal disease burden of pre-existing chronic health conditions, less access to healthcare, less access to health information. All of those things contributed to the huge racial disparities that we saw in COVID cases and COVID deaths. And so now we start to understand the importance of not just the physical environment, but the social environment and the social determinants of health. And these operate at various levels. They operate at the individual level, the way I, as a Black woman, experience life in this society is different than that of a white person. And there are ways of measuring the differences in social environment and the stressors that create health disparities. And one of the most important of those is racism, which I'm going to talk about in a minute. There are also community level social environment that you can measure at the neighborhood level. And obviously these depend on where you live. So let's talk about racism. And I've been talking about health disparities for a long time. And 20 years ago, when I would talk about health disparities and I would list racism as a cause of health disparities, there would be gasps in the audience, perhaps frowns, lots of skepticism. Very few people were talking about racism as a determinant of health. Now, much of the country has had an epiphany, and there's a very public conversation about racism, and that's a good thing because racism does underlie many of the structural inequities that continue to drive health disparities. And I want to emphasize that racism is a system. It's a system of structuring opportunity and assigning value based on the social interpretation of how we look, which is our definition of race as a social construct. This is a definition from Dr. Kamara Phyllis Jones, and I think it provides one of the most useful frameworks to think about how racism operates. Everyone acknowledges that racism unfairly disadvantages some individuals and communities. But it's only recently that we've become to talk about the fact that racism unfairly advantages other individuals and communities. And so it is a system in which there are clear winners and losers, and acknowledging if you have been the beneficiary of advantage due to racism is an important step forward. So this is the way that Dr. Jones categorizes various forms of racism. And again, I think it's a very helpful framework. There's institutional racism, now more commonly called structural racism, which really is the way that racism is embedded into our society with differential access to goods, services, and opportunities based on race. Whether it's what house you can buy, what loan you can get, what school you go to, these things are all in our society structurally embedded to be associated with race. Then there's personally mediated racism, and this is what most people think about when they think about racism, and that's differential assumptions about abilities, motives, and intent of others based on race. A belief that some races are inferior, that they are hostile, that they are dangerous, that they are less intelligent, that they are less motivated. This is really the stuff of personally mediated racism. And then very importantly, there's internalized racism, and that's the acceptance of the negative messages that you receive from society about your own abilities and intrinsic worth. And that too has an important impact on health. So understanding health disparities means understanding the complex interactions between all of the determinants of health that we've talked about, because all of those go to contribute to health disparities. And eliminating health disparities, achieving health equities, that's a heavy lift because it means dismantling all of the structural inequities that are responsible for housing instability and food insecurity and income inequality and healthcare inequities across our society for certainly for Black and Latinx and American Indians, Native Americans. But there's one part of this that I think we as healthcare providers have to own, and that is the healthcare inequities. Changing society to eliminate health disparities may not be something you feel called on to do, but eliminating disparities in the quality of care that we deliver in our healthcare system, that has got to be our responsibility as healthcare providers. Many of you will have heard of this very famous report by what was then called the Institute of Medicine. That was the most highly publicized account of the differences in the quality of care delivered to racial and ethnic minorities. And this was their conclusion. Racial and ethnic minorities receive lower quality care. This is not about access. This is looking at the quality of care that people actually receive, that it is worse. It is lower quality if you are Black or Latinx. This book looked at more than 600 papers, and so it really looked at the existent literature at that time. This was in 2003. There's probably 10 times now as many published articles documenting disparities in health care. And these disparities come from every level of the system. They operate at the health system level, decisions made by management and administrators, from healthcare professionals, providers, and from patients. At every level, there are contributions to these differences in quality. And this was perhaps one of the most startling conclusions of this report, that stereotyping, biases, and uncertainty by healthcare providers directly contributed to these differences and to the lower quality of care that are received by racial and ethnic minorities. So there's been a lot of talk since this was published about provider bias, and we know that even highly educated and socially conscious individuals are susceptible to bias. And there are certain situations that promote these biases: time pressure, incomplete information, and a high demand on attention and cognitive resources. Does that sound like your job? Because that sounds like my job in the emergency department. We work in exactly the conditions that are most likely to result in these biases emerging and disadvantaging the patients we're taking care of. This is data from the the Agency for Healthcare Research and Quality. Since 2003, they have tracked healthcare disparities, and these are differences in quality, okay, across income groups, Hispanic versus white, Black versus white, Asian versus white, American Indian, Alaskan Native versus white. And the key is that the Black, in each bar, the Black portion are the number of measures of healthcare quality that have gotten better. The blue bar are the number of measures of healthcare quality that have stayed the same. And the green bar are the number of measures of healthcare quality that have gotten worse. I believe this is over a 10-year period. And so you can see that the trend is not that hopeful, particularly when you look at healthcare quality based on income, based on Hispanic ethnicity, and based on race. These differences, racial and ethnic differences in the quality of care delivery, have been documented in every kind of care, in primary care, in cardiac care, in emergency care, surgical care, obstetrical care. Doesn't matter. Disparities in care have been documented in every single specialty of medicine. And this, I submit, is our responsibility as healthcare providers to address. This is one of my favorite quotes by Martin Luther King, and it really speaks to the fact that this inequitable care that we're delivering in our healthcare system is, wrong on every possible level. It's a moral wrong, it's a professional wrong. And if we're not actively working to correct this, then I think we should be asking ourselves why we aren't. Quality care means delivering equitable care, that you have to give the same quality of care to every patient you see, regardless of their race, ethnicity, also their sexual orientation or gender identity, regardless of the disease condition they have. That is what it means to be a professional, is to deliver the same high quality of care to every person you care for. And so I asked you, do you think you're doing this? Now, I want to point out that quality is continuously measured throughout healthcare. We have metrics for everything we do. There are metrics to measure quality in every specialty, for every clinical condition. We're required to do this by regulators. We're required to do this by payers. And so we have quantitative data on the quality of care that we deliver in our health systems. We have it at the practice level. We have it at the individual level. And what else do we have? We have data on patient, race, ethnicity, and language preference, because that is also required by regulators and payers. And so we have all of the information we need to look to see if we are delivering equitable care to every group of patients that we care for. Do you think you deliver equitable care to all patients, regardless of race, ethnicity, or language preference? I'm guessing that most of you would say that you do. My question is, have you measured that? Do you actually have evidence that you are delivering the same quality of care to all patients? And this question can be asked at the individual provider level and at the institutional level. Does this institution deliver equitable care to all patients, regardless of race, ethnicity, or language preference? And I'm happy to say that over the last year and a half, we're now looking at exactly that. We are looking at the data on quality metrics across the health system. We're stratifying it by the patient, race, ethnicity, and language preference data that we have been collecting. And we are looking to see whether or not the care we deliver is equitable. I challenge all of you to look at this in whatever quality metrics your department or division may be collecting. I assure you that if you look carefully, you will almost certainly find that there are racial and ethnic inequities in the quality of care that you are delivering. And identifying that, measuring that, and then monitoring that is the way that we will achieve health care equity. Many of you may have seen this picture before, but I'd like to show it to explain the difference between equality and equity. Equity is not giving the same thing to everyone, okay? If you look over on this side, all of the boxes are the same size. But the result is quite different, because some people got a box they didn't need, and for some people, the box wasn't high enough for them to be able to see over the fence. This is equity, giving each individual whatever is necessary to achieve the same outcome. And in healthcare, we are often in charge of handing out the boxes. And so this is why it's so important that we understand health disparities because people do not start from the same health status. Their risks are different, their needs are different, and we have a responsibility to take that into account when we're providing care for them. And in fact, as we see in this cartoon, this is our reality, where some people are starting way behind in terms of the resources that they need to achieve health outcomes, and some people have more resources than they can use. This is where we're starting from. This is where we need to get. So how do we eliminate healthcare disparities? So at the very least, we can achieve healthcare equity. And so it requires competent medical decision making. And competent medical decision making really has two components. First, you have to get accurate information about the patient that you're caring for. And obviously, bias and racism play a role in our ability to communicate with patients from all cultures in their willingness to trust us with the information that we need to take care of them. And much of cultural competence training focuses on these interpersonal skills of how do we have this cross-cultural communication? Because frankly, once you're a physician, you've already now been acclimated into a different culture than people who are not physicians. And so there is always a barrier when you're communicating with non-physicians. If you layer on top of that differences in race and ethnicity and background, if you layer on top of that language inequities, you can see how challenging it can be to deliver high quality care. But that is our responsibility. But it takes not just outstanding communication skills. Cultural competence requires knowledge. It requires prior medical knowledge, and it requires group-specific knowledge. You need to know about the differential risks of patients based on their race and ethnicity, about the varying prevalence of diseases in a given population subgroup. You need that information to make high quality medical decisions about how to care for these patients. Unfortunately, some of what is labeled cultural competence training is actually simply a perpetuation of stereotypes rather than a strategy, teaching you a strategy to use data to make the very best decisions possible for the patient in front of you by understanding as much as possible about the context of that patient's underlying health conditions and the conditions in which they live. So it requires unbiased care from culturally competent providers who understand the context in which our patients live and work. We need to be intentional about creating these conditions, unbiased care, culturally competent providers, and understanding the context in which our patients live in. So there are lots of things that we can do to achieve equity in healthcare. I've worked in a lot of places in my career, and I worked in some places where you would hear a lot of very casually phrased slurs about patients, derogatory terms used about patients, some with a racial or ethnic bias, some based on their underlying condition. And I worked in places where it was very common to hear people talking that way. And I worked in other places where such a remark would be met with 10 people telling you, we don't talk about patients that way here. Each of you gets to decide what kind of culture you want to create where you work and practice. Do you make stereotypical remarks? Do you tolerate stereotypical remarks? Or do you create a culture where people do not make such stereotypical remarks? This is something that every one of you can do that can start to make a difference. obviously good training and cultural competence, and now anti-racist training, which really means looking at the ways in which the structural racism that's part of our society has become embedded in us, and learning to not let that control the way we care for patients. Don't think that that medical Spanish class that you took in med school is good enough for you to communicate with patients. Unless you are truly fluent, use an interpreter. You only think that you are communicating well with patients. You're missing the nuances. You should be linguistically and culturally fluent if you're going to use your own language abilities to talk to patients. Now, increasing the diversity of the workforce not only improves the quality of team performance, because we know diverse teams are high-performing teams, but it gives everybody more practice with communicating with people from different backgrounds. And so increasing the diversity of our workforce is very important. Another strategy to reduce healthcare disparities is the use of evidence-based clinical guidelines. Because where there is widespread variation, because there is a lot of physician discretion and individual preference in terms of the way care is delivered, that is when the biases emerge. And so if we have clear guidelines based on evidence about how care should be delivered, implementing those sorts of guidelines inevitably will reduce healthcare disparities if you are measuring it and monitoring it. So think about that as a strategy. All of us should be monitoring the equitableness of the care we deliver in our practice. We should be looking at it at the practice level, and we should be looking at it at the individual level. And if you measure it, and I promise you, if you measure it, you will find differences, then you can develop, implement, and evaluate interventions to eliminate those disparities in the quality of care we are delivering. So, collecting accurate patient level data is something that Mount Sinai has been focused on very seriously for the last 5 years. I'm now quite involved through the Institute of Health Equity Research in looking at quality data across the health system by race, ethnicity, and preferred language, and identifying where there are issues and starting to implement solutions to address care disparities. You should be identifying the disparities in the quality of care being delivered in your practice, and then implementing evidence-based solutions to address the disparities that are identified. This is how we will achieve healthcare equity. We have to be intentional about it, but this is an achievable goal. Dismantling structural racism throughout our society and achieving equity in health, that's a heavy lift, but achieving equity in health care, this is a goal that is within our ability to reach. Okay. I'm going to mention now a couple of other things. This has been very much in the academic press and a little bit in the lay press, is issue of race-based clinical algorithms. Probably the most famous example is the EGFR. And this is an example of the way in which bias has been embedded in our healthcare system. This issue is referred to as race-based clinical algorithms, but what they really are race-biased clinical algorithms where there's a race correction, as in the case of EGFR. There was a race correction for Blacks that was based on a small study with flawed data. And this flawed algorithm has been widely used for decades, calculating kidney function in a way that has disadvantaged Black patients. Embedded in our laboratory information system, automatically calculated for you and presented with the results. Sinai, you may be aware, recently eliminated the use of the race-corrected EGFR. We eliminated it from our electronic health record. It took a work group, many months, lots of disciplines, understanding all of the ways that this algorithm was used and all of the things we would have to do to extricate it from our healthcare system. But this is an example of the kind of work we have to do. But Sinai didn't start with the EGFR, and we actually convened a task force that looked at all of the clinical algorithms across the healthcare system, identified a number of them that had race corrections, and took a deep dive into what was the original literature, the original evidence supporting the creation of these algorithms. What was the impact? Was it harm or benefit? Is there a plausible causal mechanism for having a race correction in these algorithms? And the task force made recommendations about whether or not we should continue to use these algorithms. A number of changes have already been made, including there's now a new calculator for vaginal birth after cesarean. The one that included race has been, again, eliminated from EPIC and is no longer being used by our obstetrical service. This one was really interesting, pulse oximetry. Here is a device that all of us use very frequently to monitor the oxygen saturation of our patients, and there's bias embedded in the device. It's a fascinating story. There's a long-standing literature, and it turns out that commercially available pulse oximeters systematically overestimate oxygen saturation in persons with dark skin pigmentation. Now, this was not always true, because you'll read older literature and the manufacturer's literature that says the reading is not affected by skin pigmentation. And that actually was true of the original pulse oximeter devices. But when LED technology came out, and it was introduced into the devices because it's cheap and reliable, it also introduced a bias. And there is very convincing empirical evidence that in individuals with dark or medium skin pigmentation, when your actual saturation is in the 80 to 90% range, pulse oximeters can overestimate this by 2 to 5%. So what does this mean? The pulse ox says 91, and their saturation is really 87%. So the bias is greatest exactly in that range of measurement where the clinical impact of the decision is greatest. I see this every time I work in the emergency department. I decide whether or not to send people home with COVID based on what their oxygen saturation is. But I know that if I have a dark skinned individual and I have a reading on the lower end of the scale, that I need to get a blood gas to know if that patient is actually hypoxemic. I can't rely on a pulse ox reading in a darkly pigmented individual once it gets into the lower ranges. So bias is everywhere, and we have to be diligent and persistent about identifying it everywhere we go. And I'm actually in the process of writing a grant now with some light engineers here at Sinai to develop a bias-free pulse oximeter. So more to come on that. And hopefully you will all help us disseminate it once it's invented. So I'm going to take a few minutes to do a little bit of a commercial for our Institute for Health Equity Research, which is my new professional focus, along with my colleague Carol Horowitz, who many of you know. This institute was created in May of 2020, very early in the pandemic, because Sinai decided to make the same kind of investment in health equity science that it has made in other areas of science by creating a transdisciplinary research institute to study health equity. And so the mission and vision is pretty much what you would expect. We are very focused on actionable research that will change what is into what should be. There are 4 cores. You've already heard a little bit about the activities of the Healthcare Delivery Science Core with the Clinical Algorithms Task Force. We are also engaged in looking at disparities in quality across the health system and helping practices and leaders think about how to address those. Very strong community engagement core that's doing amazing work with really dozens of community partners. I'm going to tell you a little bit more about that in a minute. We have a data and research core, which looks at all of the disease-specific disparities and uses big data to help us understand and monitor progress on disparities. We also have a research workforce core that I'm going to tell you a little bit more about. One of the first things the community engagement core of the Institute did is a Speak Up on COVID survey. Some of you may have seen this. It's a community-based survey in 11 languages. We've gotten over 2,000 responses. And the responses were fascinating because in the midst of COVID, with worry about the disease and the economic devastation that COVID has wrought, people have been laid off. When they lose their jobs, they lose their insurance. They're worried about paying their rent. They're worried about feeding their families. And what became very high on people's list of concerns is the mental and emotional health of people in our communities. And so we've done a number of town halls that are really focused on the mental health impacts of COVID and what are the strategies that we should be rolling out to address that particular aspect of the COVID pandemic. The Institute was recently funded by NIH to be part of the Community Engagement Alliance for COVID, doing a lot of work in communities about vaccine acceptance, understanding the sources of distrust, the sources of disinformation, and working with community partners to improve vaccine confidence, as well as to encourage participation in COVID-related clinical trials. And then I just want to mention that the Workforce Core also has a couple of things we'd like you to know about. The goal of this core is to transform both the composition of the research workforce, but also the focus of the research workforce. I talked before about the complicated set of determinants of health and the complexities of understanding health disparities. We need scientists from every discipline, basic through translational, clinical, health services, all scientists to start to look at their work with an equity lens. If we're really going to understand and eliminate health disparities, we all need to be looking at race and ethnicity in our work, whatever it may be. And so we've launched a disparities consultation service where if you are a researcher and you would like to add an equity focus to your research, you can get 2 hours, up to 2 hours of expert consultation with an experienced disparities researcher to help you think about how to measure race, what kind of theoretical models you could be using so that you can start to bring a health equity lens into your research. We also have taken over providing technical assistance for research diversity supplements. And so if you're a trainee or a young faculty member or a student who's a member of an underrepresented minority and would like to get more information about how you might be supported by a supplement, a diversity supplement, please reach out to our institute. And then one last thing, the Institute is very involved in this large grant, which Sinai just received. It's a partnership with 3 of the other research-focused institutes, the Freedom Brain Institute, the Tisch Cancer Institute, and the Institute on Emerging Global pathogens. This is a $17 million grant to do a cluster hire of underrepresented minority research faculty, along with an extensive set of strategies to really change the culture at Mount Sinai to promote their research success by creating a culture of inclusive excellence. And so if you are someone who's involved in recruiting or hiring research faculty, please reach out to me for more information about that as well. We have a few minutes left, so I'm going to stop there. I would be happy to take questions about any of the things I've talked about. And I thank you for this opportunity to talk to you about the things that all of us can be doing to work to achieve health equity and, more immediately, healthcare equity.
Thank you so much, Dr. Richardson. That was really a phenomenal talk, and I think probably has inspired a lot of people with in terms of what they can do individually and as a group to achieve healthcare equity. Perhaps if I could ask you a question first, and then there's some questions in the chat. So the first thing is that we have a lot of busy clinicians on the call, and I think everyone is interested in pursuing healthcare equity. But what is some of the low-hanging fruit in terms of ways that we can look at our practices, that we can start to at least measure some of these potential disparities and to try to act on them?
Well, the interesting thing about looking at healthcare disparities is you probably already have all of the data you need. You simply need to merge the quality metrics that I'm sure all of you are collecting with patient level data on race, ethnicity. And I have to tell you that sometimes there is very low hanging fruit, that there are relatively simple things that can be done that will make a huge impact on the quality of healthcare that you're delivering very quickly. And not all of them cost a lot of money. I usually take the approach that, if you think achieving healthcare equity will require everyone to do an intense, process of self-reflection to eliminate bias and to become an anti-racist individual, that could take years. But there are very simple things we can do that will change the way people behave in the clinical workspace. And there's actually a lot of literature on interventions that will eliminate healthcare disparities. We just have not had the will to implement them. We have a research study, we gather the evidence, we prove it works, then the grant is over, the intervention is dismantled, and nothing has really changed. And so the focus now has to be on implementing the things that we already know work, like using evidence-based guidelines, like embedding clinical decision support in the electronic health record. Now, I know you all hate the alerts and all of the messages that come at us in Epic, but actually those are very effective ways. Just measuring the differences can in itself be an intervention. And this is something that, people who work in quality improvement have learned. If you pick any metric and you look at it by race, ethnicity, and you find that some of your providers have a disparity based on race, the first very simple thing to do is to feed that data back to them. This is often done in quality improvement, and what you do is that you send, a message to, let's say, the bottom quartile, and say that, in January, you ranked in the top 25% of providers who had, racial differences in, anything, hemoglobin A1C of patients, blood pressure control, pick any quality measure. If you tell a group of physicians they're in the bottom 25%, I promise you the next quarter, they will all have improved. Now there'll be a different group who's in the bottom 25%. And when they get the notice, they will improve. And so what happens? The actual performance keeps rising just out of the competitive nature of the physicians. It doesn't matter if they're woke. It doesn't matter if they believe in equity. If you just tell them that their performance is substandard, they will change it. And so that's a very simple way. And I have used this a number of times to improve quality in my own career. Very simple thing that everybody can do. You're probably already collecting these metrics. Just add an equity lens to the data you're already collecting.
Perfect.
Other questions?
Yeah, there's actually one question in the chat, which is, has Mount Sinai been studying ways to improve vaccination rates in various communities for COVID-19? And would you happen to know what were some of the results?
Yeah, so this has been very interesting work. So the important thing to understand is that community engagement is about building relationships. And so some of us who've been working in this field, particularly Carol Horowitz, who really is a stellar community-based participatory researcher, over the years has built trusting relationships with dozens of community-based organizations, everything from emergency food service providers, advocacy groups that work with the homeless, that work with justice-involved populations, LGBTQ+. And so from having done work with these community organizations, treated them with respect, listened to their concerns, there's now strong relationships. And we were able to draw on those when COVID broke out. And that's really how we wound up with the survey. Carol sent out an email to over 100 community-based organizations, and almost everyone responded saying, yes, we want to do something about COVID. Let's talk about what we should be doing. And out of that came the COVID survey. Now, the vaccination work is really about getting trusted sources in the community to talk about why people should get vaccine. The public health officials talking, that only goes so far. You as providers talking is very important, but that only goes so far. People in the communities who look like them, telling them, I've done it and this is good for you, takes it even further. So we've been working closely, for example, with the New York City Department of Health and Mental Hygiene. They have a mobile van, and their most successful vaccination events have actually been at community partners that we identified. They went to the New York Common Pantry, and the same people who had been handing out emergency food week after week to their clients said, listen, I want you to come over here and get this vaccine. It's good for you. And 220 people got vaccinated in a single afternoon. That's how you do the work, by having trusted people in the community spread the message. We have health navigators that we've trained. They're out in the community. They're just talking to people about vaccines, hearing what it is that people are hearing, what are they hearing on social media from their friends, and then talking that through to change the way they feel about vaccines. So it's very much on the ground, out in the community work, but we are making progress.
Thank you so much, Dr. Richardson. This was an incredibly thoughtful talk, and I think, again, one that's very meaningful, very impactful to a lot of people. So thank you so much for sharing your experience.
It has been my pleasure. Thank you for the invitation. And please reach out to us at the Institute for Health Equity Research if we can be helpful in implementing or monitoring interventions that you are using to try to achieve healthcare equity in your own practices. Thanks. Bye-bye.
Thank you so much. Have a great day, everyone.